So, just to complete, we had a one session on a FLACS also. Dr. Mahipal could not come. So femtosecond laser application in cataract surgery is a assistive tool. It's not a complete surgery. That we have to make patient understand is assistance to the routine phaco surgery. Then you can go ahead with the normal surgery for these patients also. There are certain situations where femtosecond laser may have advantage. One of them is a wide cataract with intumescence. Second is a posterior polar cataract, and third is a subluxated cataract. Fourth is a patient who desires femtosecond laser. There you should do it if they have no contraindication. Any person who says I want to get a femtosecond laser done, yes, why not? If you have a system with you, do it, because it's going to give us advantage of your capsulotomy, incision, and fragmentation also. So this is what femtosecond application gives you a nice anterior capsular picture, as well as it has an OCT attachment which can tell you the corneal profile, AC depth, the bulge in the anterior capsule. You can plan the depth of nuclear fragmentation and its configuration, and it also tells you what is there in the posterior part also. You can pick up the posterior polar cataract, you can pick up the open posterior capsule also in these cases. In wide cataracts, the advantage is more on a capsulotomy, not on a nucleotomy, because nucleus energy will not reach there, so you may have to do manual surgery. It is only the capsulotomy where you benefit, and whatever happens, the tear is not going to extend to the periphery because everything is happening in a closed chamber. So the pressure will get released. But the chances of tear going to periphery is minimal during the laser application. So see, this patient is a femtosecond. We are doing an intumescent wide cataract. So I plan for a fragmentation because that's not going to affect it. This is the planning for a application here. Now I'm doing here. You can see the application here. You'll see this explosion of a fluid coming when you actually make a puncture. The laser makes a multiple punctures onto the anterior capsule, and some area the fluid will come out in a significant area. So there is a cut. This area you may have a little addition because the capsule gets flattened and application laser may not be appropriate in these cases. So nucleotomy is now completed. This is the incision being done, side port incision. Now we'll shift the patient to main OR. Always stain the anterior capsule. So this was the area of explosion. So we'll have open capsule. Here you may have additions. So I would be doing a similar procedure as you do for capsular access. Rotate your hand. So these are one attachment here, one attachment here. So take a forceps and just tear it off. So you should be little gentle. You can do with a needle cystitome also. There was a one attachment there. And this is one area. I'll just tear it off, one attachment. The idea to show here is you can manage raised interlenticular pressure with femtosecond laser also, and do a nice capsulotomy and subsequently do a emulsification as you do for routine cases. This is the relatively softer cataract which you see in some of the wide cataracts. Some of the wide cataracts who would have a totally Brunenses nucleus also sometimes. So this is how you manage. This is another patient. I'll show you a similar patient here. Again, you see this area of OCT. It has a lot of fluid pockets. And as soon as you make a laser opening, again the blast will happen. This blast happen in two areas here. So here in these cases, you'll have a skip area in these cases also. So I'll do again a staining here. You can see this is the area I was worried about. We had a opening here or opening here. I'll do a same rhexis opening in these cases and safeguard the rhexis tear going to periphery. So we have compared wide cataracts with manual surgery rhexis and the capsulotomy in these cases. The outcomes are almost similar, manual versus femtosecond laser. But femtosecond laser, we had a more circular capsular rhexis and the capsulotomy, and chances of tear extension during procedure in both the cases are comparable. We had one case in series of 80 cases in each group. Let me show one in a posterior polar cataract. As I said, this is one area. You can see the entire posterior pole of in the OCT. So this patient didn't have the open posterior capsule, but we could initiate the procedure here. So this is a technique described by us where we do a capsulotomy, the posterior polar cataract of around 4.9 millimeter size. Then we're doing this as a hybrid technique. We'll do 3 layers of nucleus, you can say delineation, femto delineation, and 8 softs. So this is three rings of delineation and chop pattern being done. Idea here is to have uh, three blocks of a nucleus, and you can take out one block at a time without rotation of entire nucleus or a posterior epicortical cushion. So I'll shift this patient to OR now. You'll see the technique here. We can translate into the manual surgery also. So I'm removing the free floating capsulotomy here. So I have a multiple chops here. Then I won't do a hydro dissection delineation at all. I'll open this chop. You can see the bubbles will escape. And once the bubbles escape, the pressure goes down and fluid seeps into the space here. So this is the first block in the center. The second opening I'm doing again. Now I'll take primary block. I'll remove this block now. This is called block by block disassembly of nucleus fragmentations. You just use a second instrument, pull this piece to a center, remove that. There's no disturbance of the peripheral part of lens and epicortex. So this is how advantageous femtosecond can be. You can do entire manipulation without a rotation of the segment of epicortical cushion here. Now I'll go to epicortical cushion and remove one by one. By the time the fluid would have seeped into a space and gives you an internal hydrodissection also and complete the surgery. So these are two areas where femtosecond laser may be advantageous and gives you a nice assessment of your case and complete the surgeries subsequently also. And this is the application in subluxury cataract here. You can see here, this is a very difficult case. And if you see here, classically, the OCT tells you have a little decentered appearance because this is nearer to the pupil iris and this is away. So this is the area of subluxation and this is the bolus of vitreous in the anterior chamber. So despite bolus of vitreous, I can do a capsulotomy in this particular case. It's not contraindication that you have a vitreous, you can't do a capsulotomy. So I do a little posterior, as somebody was asking. This is how the posterior it is, a little bleeding coming out. Stain the capsule here and do a, okay, what's gone wrong? Then put the hooks and put a tamsunolol to see the vitreous there and do a proper vitrectomy. Then take out pieces. You don't require to do a hydro procedure here again. You can remove each piece as you saw in the posterior polar cataract and remove the epicortex subsequently area. You can see the capsulotomy is very nicely, can handle the pressure of hooks also. It's not that laser capsulotomies are very, very weak. They're as strong as a Rexis. And here again, after completion, before I remove my handpiece, I'll inject the, viscoelastic there, put CTR and complete the surgery. So these are three important areas I consider femtosecond laser advantageous. Apart from that, you can see the OCT picture also of your case, and the morphology of situation difficulties in posterior polar and in wide cataracts and subluxury cataract also. After completion surgery, I've done the vitreous management. Subsequently also, you might think you have done a complete vitrectomy. There may be one tag there. So after completion also, use a tamsunolol, stain the entire area and cut that, and you have a very nice pupil subsequently also. Thank you. If any question, we can take subsequent.
Thank you very much, Dr. Tijal, for the beautiful videos. Any question or any comment from the house? Yes.
What is the effect of femto on the vitreous?
You mean to say cases like this where you had a vitreous in antechamber? In this particular case, you saw that if the vitreous is there, when you're applying the laser, there was a sort of a jelly formation because the vitreous will not have a bubbles which you normally see in a clear anterior chamber where the aqueous is there. Here, no bubbles were there, jelly formation was there. That indicated you are hitting the vitreous. So this may have a traction happening sometimes in the periphery. So you should be a little careful in the post-op period and you should do a proper analysis. I normally do a first day indirect in all these cases, do a posterior segment OCT and follow up these patients regularly in a few months and give them two tips. If you see a drop in vision, you have a flashes and floaters, immediately rush to hospital because that may be a signal for something going wrong. So that's a very important part. Whenever you have a vitreous and you do a vitrectomy, vitreous management, the post-op care has to be very, very meticulously done.